Hey, this is Dr. Nick with the ECG Academy, and we're going to continue our discussion of atrial fibrillation in this video. I'm going to show you a bunch of examples and show you how easy it is to diagnose it, but I also want to show you some things that you need to worry about so that you don't make the wrong diagnosis. Anyway, looking at this ECG, taking a look at the forest, you can see that there is some irregularity. The QRS complexes are clearly not marching through at a regular rate. And if you try to look for a pattern in it, you won't find one. And that's the hallmark of atrial fibrillation, and it's irregularly irregular. There's no real pattern to it. If there was, you would call it group beating and start looking for some kind of second-degree AV block. But atrial fibrillation should be irregularly irregular. The rate over here is on average about 80 or 90 beats per minute, and we'll keep that in mind when we go to label this arrhythmia. Looking at the R to R interval, the longer intervals are where you're more likely to be able to see what's happening. And what you can see is this sort of undulation of the baseline. The key here is that the baseline does not have a consistent electrical signal. Remember, the difference between atrial fibrillation and atrial flutter is that in atrial flutter, the signal is going round and round in a circle, or less often, there's a focus that's firing rapidly and the signal is spreading rapidly across both atria in a very consistent manner. Either one of these situations gives rise to a very discrete, very reproducible, very consistent atrial signal that is regular and each beat looks the same. These flutter waves should look the same in the same lead over time. So the difference is atrial fibrillation is more of a chaotic problem. The signal is traveling in different directions, and it never really takes the same pathway twice. And so there should be no pattern to the electrical signal that you'll see. In fact, if you look at V1, you might be tempted to call this atrial flutter. You got these large, kind of fluttery-looking, almost sawtooth waves here in V1 that clearly are going upright. But at this part of V1, you can see that those waves are now going down. And so this is really more of a polymorphic or a variable, constantly changing rhythm. And even though it's kind of on the slow side for atrial fibrillation, we call it coarse atrial fibrillation to refer to the fact that the fibrillatory waves look very large and chunky looking, almost like flutter. And in reality, the atrial rate may slow down briefly where it could be in the range of 300 beats per minute, but at other times during the arrhythmia, it actually may be quite a bit faster. Here is clearly 350. The rate's constantly changing. The signal is constantly changing as well, and that's why we call this as a polymorphic arrhythmia, meaning the appearance of each individual signal varies over time. To sum it up, we have this irregularly irregular rhythm with this polymorphic, chaotic-looking baseline. In some areas, it looks like flutter, but clearly it's changing, and so it's not flutter. It's atrial fibrillation with a moderate ventricular response. Okay, let's look at the next one. This is the kind of cardiogram you'll see frequently in an emergency room, and when you first see it, it's very impressive, and the patients are usually rather uncomfortable. Glancing at the rhythm strip, you can see it's really quite rapid. The average heart rate here is over 150 beats per minute. It has to be in the range of 165 to 170. It's irregular. There doesn't seem to be any pattern. You get very rapid beats here, in fact, exceeding 200 beats per minute. If you look at this beat and this beat, it's less than 3 boxes across. So we're talking over 200 beats per minute in this one little brief area, and then it slows down a little bit further down here. But there's no pattern to it. So you have this irregularly irregular rhythm with a very rapid rate. Trying to accurately diagnose this as atrial fibrillation now is a bit of a challenge because you're really obligated to rule out other things. Things like multifocal atrial tachycardia or atrial flutter with variable conduction. And so it's important that you look in front of every single QRS complex, especially the ones with the longer R to R intervals, to see if you can get a sense of whether there is any kind of a consistent P wave in front of each beat or whether there's a consistent flutter wave that's marching through the entire strip. You really have to look at every single lead, especially V1 and the inferior leads, to look for flutter waves. Once you're satisfied that you don't see anything that looks like a discrete P wave or some kind of organized atrial activity, then you can call this atrial fibrillation with a rapid ventricular response. Some people use the term rapid AFib, and that's kind of a confusing term because the atrial rate is rapid all the time. It's 350 beats per minute or better during atrial fibrillation. So all atrial fibrillation is rapid, even the kind that has a slow ventricular rate. You get my point? Does the word rapid refer to the atrial rate or the ventricular rate? When you say rapid AFib, it's a little vague. So atrial fibrillation with a rapid ventricular response would seem to be the more accurate diagnosis, the better way to say it. Okay, we'll go on to the next one. Now, the first thing that should stick out at you is that the ventricular rate is extremely slow. In fact, if you look at this beat right here, find a heavy line and count off the milliseconds. 1, 2, 3, 4, well, that's 1 second. 1, 2, 3, 4, that's 2 seconds. 1, 2, 3, 4. This would be 3 seconds. So at 3 seconds in between beats, an R-to-R interval of 3 seconds would be 20 beats per minute. So this is more like 22 beats per minute or so. So with a ventricular rate of 22 beats per minute, what could this be? Well, you'd want to look for P waves because this could be a severe sinus bradycardia. And you look at this and you say, wow, does that look like a P wave? Maybe it is. But then again, it's not really present in any other leads. And so I suspect that's just artifact. I'm pretty sure the patient just simply moved. What you should be able to notice is that the baseline has this very, very fine undulating pattern to it. It has this little sense of atrial fibrillation, continuous, irregular, almost noise-looking signal. And so the atrial rhythm is AFib. But now, would we call this an atrial fibrillation with a slow ventricular response? Or, well, with a rate of 22, why don't we call it atrial fibrillation with an extremely slow ventricular response? Well, that doesn't really cut it either. If we take our calipers and move it to the first R-to-R interval and set it there, and then check the next R-to-R interval, we'll see it's about the same. And the third R-to-R interval is as well. And so the ventricular rhythm here is regular. Now, we talked about the hallmark of atrial fibrillation being an irregular ventricular rhythm. So how do you explain the fact that these QRSs are very regular? Well, this has to be some kind of escape rhythm. In other words, during atrial fibrillation, the AV node determines how fast the ventricular rate goes. But because you've got these very rapid signals hitting the AV node is going to let sort of a random signal get down to the ventricles, and that gives rise to this irregular ventricular response. But if you have complete AV block, then what happens is none of the atrial fibrillation signals gets through. And instead what you get is some kind of escape rhythm coming from either the AV junction or the bundle branch or Purkinje system. So the fact that you've got this heart rate of 22 beats per minute and the QRS is rather wide, it's looking at about 180 milliseconds wide, you'd have to call this an idioventricular escape. Idioventricular probably coming from the Purkinje system. But the rate is consistent with an idioventricular rhythm, and the fact that it's regular tells you that it's an escape focus and not just simply slowly conducting atrial fibrillation. So you'd call this strip atrial fibrillation with complete heart block and an idioventricular escape rhythm. Now, of course, you can have AFib with a slow ventricular response, and you can see rates in the 40s and 50s, but the R-to-R interval should be irregular. If it's not irregular, if you have regularization of atrial fibrillation, that implies that you have complete heart block. And sometimes people will read it as atrial fibrillation with a competing junctional escape or fusion or regularization, implying that the AV node conduction is hanging by a thread and there are a lot of junctional escape beats that are sneaking through. You can see that if the majority of the R-to-R intervals are very long and fairly constant. Anyway, let's look at one more ECG. And this is actually a rhythm strip that I got from the telemetry unit. If you look at the forest, you can see the QRS complexes do appear to be irregular. This is a bit shorter, and then it's longer, and then shorter, and then longer, and then a couple of intermediates, so there's no pattern to it. looking in between the QRS complexes, there does appear to be sort of an undulation in the baseline. There doesn't seem to be any discrete flutter waves. Rather, there's sort of this polymorphic electrical signal that's going on. Here you might say, oh, gee, that looks a little sawtoothy looking. But that's not consistent. You don't see it here, and you don't really see it anyplace else. So you'd call this atrial fibrillation with a moderate ventricular response. But now let's look at the second strip. Now the QRS complexes appear to be quite regular. And if you try to figure out a rate, you have 300, 150. It's a little under 150. It's probably about 135 or 140 beats per minute. So you have a regular rhythm at 140 beats per minute. Remember what I said, don't ever believe what someone else has written on a rhythm strip, because it says here, patient converts to regular sinus rhythm, sinus tach at 136 beats per minute. Well, this is usually a patient who's just lying there watching the Discovery Channel, and having a sinus tachycardia at 140 beats per minute would be highly unlikely. You do see discrete atrial signals in front of the QRS complexes. I think that bump right there could easily be interpreted as a P wave. But given that the patient was just in atrial fibrillation a short time ago, it's much more likely that the patient's chaotic atrial fibrillation became organized into an atrial flutter. And what you have down here now is atrial flutter with 2-to-1 conduction, where one conducts and this one blocks, and one conducts and this one blocks. So you have this atrial rate at 280 beats per minute, and it's just every other signal is getting to the ventricle. So this kind of rapid regularization of atrial fibrillation is indirect evidence that what you're dealing with is atrial flutter. And people can have atrial fibrillation and atrial flutter that are sort of going back and forth between each other. You don't usually have them both at the same time, although a lot of people will kind of use the term fib flutter to imply that it's kind of somewhere in between, although one can argue that there is no such thing. It's either flutter or it's fibrillation, but not both. Well, that's a debate I can have with myself in the advanced course, but for now I think we've talked about atrial fibrillation enough, and I hope you have a better idea of how to diagnose it. In the last chapter in this section, we'll talk about atrial fibrillation with aberrant conduction, which can give rise to some really confusing-looking wide QRS complex tachycardias, and I'll explain to you what Ashman's phenomenon is and how you can use that knowledge to distinguish between atrial fib with aberrancy versus some kind of ventricular tachycardia. So for the ECG Academy, this is Dr. Nick. Thanks for watching.